sharing your experience and make the whole world smile. By your kindness and talent and sharing your commitment to help the whole world smile. By your passion and intention, sharing your experience and make the whole world smile. By your kindness and talent and sharing your commitment to help the whole world smile. By your passion and intention, lend us a hand. By your passion and intention, lend us a hand. Come to join with us, ICD, give us your hands.
Welcome to our webinar. We're going to start in a few minutes' time. And please hang on as our speaker will join us in a short while. Okay. Okay. Hello. Hello. You hear me? Sorry. You can hear me? I mean?
Yes, Prof, we can hear. I can hear you.
All right. Sorry for the hiccup just now. Welcome to our monthly webinar. And in the first place, I would like to wish all our regular attending this webinar Happy New Year. And of course, those who have celebrated Christmas, Merry Christmas, and hope that you have a good holiday and celebration, and welcome to our New Year. So this webinar we've been carrying out this webinar for the last 2.5 years. This is the third year, starting with COVID, during the COVID time in 2020, and now we are moving into the post-COVID era. We'll begin this year session with orthodontists. And of course, I would like to introduce our moderator today, Dr. Amy Amelia. She is our education committee members, and today she will introduce have the honor of introducing the speaker from home country. Amy, the platform is yours. Go ahead.
Okay, thank you, Professor Ibrahim. Good evening, ladies and gentlemen. My name is Ami Amelia, and I will be your moderator for today. And I also would like to welcome to all the participant, ICD member, and also IPROSI member, because tonight we have a collaborations with Indonesian Prosthodontic Associations. And today our speaker will be from Indonesia, who is Dr. Mefina Kuntjoro. Good evening, Dr. Mefina.
Yes, good evening, Dr. Ami, and also Prof. Ibrahim. Nice to meet you all.
Good evening. And before we start, allow me to read our speaker curriculum vitae first. So Dr. Mefina is a consultant in complex prosthodontics and implant dentistry at Airlangga University, Surabaya, Indonesia. And she obtained her dentistry degree and prosthodontic specialist degree from Airlangga University. And in 2021, she graduated from doctoral program at Airlangga University. And currently, Dr. Mefina is actively working as a staff in Department of Prosthodontic in Erlangga University since 2005. And she also joined some trainings for implant dentistry and was invited as a main speaker and hands-on instructor by many national and international seminars. And she also have her own private clinic since 2003, and her research interests are in implant dentistry and stem cell therapy for systemic disease, including diabetic patients using human umbilical cord mesenchymal stem cells. And she obtained many fundings for her research and have collaborated with Tohoku University, Japan, since 2016. And Dr. Mefina has published many papers in international journals, and she also won in Fixed Denture and Implant Awards in 12th Biennial Congress of Asia Academy of Prosthodontic in 2021, and also has won Outstanding Poster Award of International Symposium for Interface Oral Health Science in 2022. And for the title for her lecture today will be Considerations for Implant Placement in Diabetic Patients. Before we start, allow me to briefly discuss our webinar for today. So we will have around 50 minutes to 1 hour lecture time, and then we will have a question and answer after the lecture. So if you have any questions for today, please write in the Q&A box or in the chat box. We will address your questions at the end of the sessions. Okay, so let's, without further ado, let's start the webinar. Dr. Mefina, the time is yours. You can share your screen.
Okay, let me share my screen first. Okay. Is it okay, Dr. Ami?
Yes, it's okay.
Okay. Okay, can I start?
Yes, please.
Okay. Okay, selamat malam. Good evening, all professors and doctors. Thank you for joining me in this webinar. Hopefully this topic is interesting enough to make all of you not sleepy in the next 50 minutes, of course. Thank you also for moderator for your nice and warm introduction. So I repeat once again, I'm Mefina Kuntjoro, a prosthodontist from Surabaya, Indonesia. Actually, it's a really great honor for me to share knowledge with all of the colleagues here. First of all, I would like to say thank you very much for the committee for the invitation in this ICT section 15 today. My lecture topics is consideration for implant placement in diabetic patients. I will share with all of you what the important things we should be aware so that the implant placement in diabetic patients can have the same survival rate as in normal condition. Okay, before starting the knowledge, I would like to introduce my country, Indonesia. And here we can see the Indonesian map. Indonesia is an archipelago state, consists of thousands of islands and have 37 provinces. I live in Surabaya, located in Java Island, East Java province. Surabaya is the second largest city after Jakarta as Indonesia capital city. Once you visit East Java, this is the tourist destination, which is Mount Bromo, located in East Java, famous for its spectacular sunrises and majestic views, just 2 hours driving from Surabaya. I suggest to prepare warm clothes because it's very chilly in the morning. After seeing the sunrise, you can explore the crater and also Whispering Sands for another unforgettable experience. Okay, I'm working as a lecturer in the Faculty of Dentistry Universitas Erlangga, founded by Netherlands in 1928. It was called Stovit at that time and was the oldest dentistry school in Indonesia. There are 13 departments in our faculty, and I joined Department of Prosthodontics since 2005 until now. Our department have undergraduate, residency, master, and also doctoral program. And here is the picture of our 15 staff in Department of Prosthodontics, Universitas Airlangga. Hopefully you can note it where I am. Okay, now back again to the topics. Why I think the issue about diabetes is important to discuss is because according to the data from World Health Organization reported in November 10, 2021, that the prevalence of diabetes has been rising yearly and was the ninth leading cause of death. This happened in all around the world. Actually, healthy diet and physical activity can avoid and delay the onset of diabetes or maintain blood sugar level after diagnosed with diabetes. And later, I will discuss why I think that diabetes have a very close relation with us as a prosthodontist. Let's see, what is diabetes? Diabetes is a very famous and characterized with the presence of hyperglycemia. It's classified into 4 groups with its type 1, type 2, gestational diabetes, usually happening during pregnancy, and another type, but it's not common. And type 2 is the most common type of diabetes, which is around 90%. But all types will show the same condition, which is known as hyperglycemia or high blood sugar level. So this is the clinical feature according to the type of diabetes. So here I want to note the important things that in few years ago, maybe type 2 diabetes mostly develops in people over 45. But recently we can see that young adult teens or even more and more children are also developing diabetes. So I think this is a warning that we all should be aware if the patient we see have a overweight, obese, or have family history, it's better to ask for medical record, or for some prosthodontic treatments such as implant, I think we must consider like a blood test examination. Okay, a quick review about how the blood test for diagnosed diabetes, which is first is A1C. We can measure the average blood sugar for the past 2 to 3 months, and this no need to fast. If the range below 5.7 means normal, and if in between 5.7 to 6.5, it means pre-diabetes, and if it more than 6.5 means diabetes. And nowadays, this is the most common test to evaluate patient blood sugar level. The other test is FPG, or fasting plasma glucose. So patient in this test need to fast for at least 8 hours, but they can still drink water, and usually done in the morning before breakfast. If it's more than 100, we must be aware about pre-diabetes condition. And if it's more than 126, it means already in diabetes stage. The next is OGTT, or oral glucose tolerance test. This was done 2 hours after drinking something very sweet. This test can measure how well your body can process a larger amount of sugar. This is another value for FPG, A1C, and OGTT, which is in micromole. If in the slide before was performed in milligram, this can also be converted in micromole, as shown in this slide. The most important point in this slide, if no symptoms of hyperglycemia, such as increased thirst or frequent urination or increased hunger or weight loss, fatigue, but single test confirmed diabetes, it's better to repeat the test another day to prevent misdiagnosis. Now, how to treat diabetes? Lots of people with type 2 diabetes, as we talked about 90%, don't take any medication. They instead treat their diabetes with eating well and moving more. And the latest results have even shown that weight loss and healthy life can put type 2 diabetes into remission. But for some people with have a very high blood sugar level when they are first diagnosed, Insulin can be short-term treatment to help quickly bring down their blood sugar levels, then continue by changing their lifestyle. And this I will show the journal about the successful Mediterranean diet and also this diet to reduce the risk of diabetes. Okay, what is Mediterranean diet? This diet includes fruits and vegetables and also whole grain. With this diet, patients will be able to manage their disease without diabetes medication. And this is the DASH diet. Almost the same ingredients, but have other benefits such as insulin, improve insulin sensitivity, and promote weight loss. Okay, now let's discuss what is the relation between diabetes and prosthodontitis. If in the last slide, we can see that fruit and vegetables are recommended for healthy diet. But unfortunately, many literature reported the risk of periodontitis in diabetic patients is 3 times that of non-diabetic patient, and in the end will cause the tooth loss. This can lead to unsuccessful diet because of less chewing ability. So why this is happen? Because in diabetes, the growth of anaerobic gram-negative bacteria which can form plaques around the teeth and gum is increased. If this plaque is not removed by personal hygiene, it will become calcareous, result in periodontitis that can lead to the loss of bone and ligaments surrounding the teeth and eventually leading to tooth loss. Just to make sure about this issue, this is a lot of literature reported the close relation between diabetes and tooth loss. Okay, so the conclusion of this study is that the lower number of the teeth will associate with lower masticatory ability. The chewing ability was also related to systemic markers such as A1C. A high level of A1C was suggested to be associated with poor masticatory function and severe periodontitis. With this finding, to support dietary management in diabetes patients, as mentioned before, patients need good masticatory, but they don't have enough tooth to support this. So I think this is our responsibility as a prosthodontist to restore the missing teeth and increase patient chewing ability. So the question is, what kind of prosthodontic treatment should be done to support this diet in diabetes patients? In this journal, reported the changes from traditional removable partial denture, and then after 1 year, the same patient received implant-supported RPD with an implant, a ball, or locator attachment. Then patient will ask to fill the oral health impact profile questionnaire. The results showed that there's a significant improvement after rehabilitation. Also improve the quality of life with benefit in chewing ability, aesthetic, and self-satisfaction. So I think all of us also agree that implant can restore masticatory function back about more than 90% only in few weeks after loading. Okay. So the next question is it safe to put dental implant in diabetes patient? So before focusing in this kind of research, I myself, when facing patients with diabetes, usually ask them to lower their blood sugar level first before proceed with implant placement. But according to my own experience, after waiting for several months, usually they come back and show no significant progress of their blood sugar level. At that time, I make conclusion that the critical point here is that medication itself cannot work well if not combined with good mastication to support healthy diet. So let's see what factor is important to have successful implant placement. Dental implant have to also integrate it well so that it can function and restore mastication. I conclude that 3 factors that really have a great impact on the osseointegration within patient-related factors, implant surface design, and also the clinical procedure. Now, the problem in diabetes is very focusing on the patient-related factors, because in diabetes condition or hyperglycemia will cause disturbance such as delay or decrease implant osseointegration. Okay, now let us discuss one by one and the solution about how we can make a solution for diabetic patients. So the first is about the patient-related factors. For diabetic patient, according to A1C level, we will stratify it into 4 levels, which is well controlled if the A1C between 6.1 to 8, moderately controlled, which is 8.1 to 10, and poorly controlled, which is more than 10. While for healthy control, the A1C should be less than 6. In all of the journal, this is very well established about diabetes. Okay. How about the dental implant survival in well-controlled diabetes? We can see that this journal reported the correlation between diabetes and gender, implant location, the length of the implant for well-controlled A1C, which is below 8. The conclusion is no significant difference for implant failure for male or female patient. The survival rate is greater in the mandibular arch, especially in the implant were placed anteriorly. The length of the implant had no effect on the survival rate of the implant. So it can be concluded that for well-controlled diabetes, if the A1C under 8 do not have additional risks in the failure rate of dental implant in comparison with healthy individuals. Now, how about dental implant survival rate in poorly controlled diabetic patients? So patients with poorly controlled diabetes have lower stability at the first 2 to 6 weeks, but in the following weeks, stability will reach the baseline again. This finding also agree that the patient with poorly controlled diabetes seems to have delayed osseointegration, but after 1 year, no difference between diabetics and healthy individual. So it's better to avoid immediate loading implant for poorly controlled. The survival rate of implant in diabetics does not differ for the survival rate of patient until 6-year follow-ups. But for 20 years, it will need more observation. Okay, this is other journal that also reported that the high levels of survival and low levels of failure in implants for diabetic patients, and they make a follow-up until 252 months. But of course, the hyperglycemia will increase the risk of peri-implantitis. In this slide, I will discuss how about the bone quality and diabetes condition. As we know that bone density can be categorized into 4 types. Type 1, which is a very dense cortical bone or the hardest alveolar bone, while the type 4 is the fine trabecular bone or softest alveolar bone. We can see from the graph that the survival implant rate for both non-diabetics and type 2 diabetes was generally similar for bone qualities type 2 and type 3. Lower survival was found in bone qualities type 1, but not significantly different. But for type 4, this one shows significantly different. So this is a consideration that with patient type bone density, we better to postpone the loading implant and sometimes need double time for osseointegration compared to the normal patient. Okay, talking that the patient with diabetes will be more prone to peri-implantitis. So we can see how to identify the identify the peri-implant disease. We can have three methods, which is to check the marginal bone loss, or MBL. This is considered as an important factor in evaluating the quality of survival bone, as bone loss will lead the formation of the pockets. Well, for probing depth and BOP, or bleeding on problem, are the parameters of peri-implant inflammation. Changes in the three indicators listed above may ultimately lead to adverse implant outcomes. So we can see this in this journal. The aim of the study is to explore the possible association between diabetes mellitus and dental implant complication. They also use the three parameters, which is MBL, PD, and also BLP. And result is a higher MBL, PD, and also BOP in diabetes patient. BOP will increase along with the increase of A1C. So after the implant insertion, it's better to ask the patient to check regularly and maintain their A1C to prevent peri-implantitis. So how to check the implant stability? So the first method is the clinician perception. This is based on the seating torque during insertion. The perception of good stability is by the sensation of an abrupt stop when the implant is seated. And then the next is torque based on the clinical tactile. This will measure the rotational friction between the implant surface and the bone. And we can use the percussion testing. You can use tools like a mirror handle, but this is a highly subjective and insensitive to changes in implant stability. All these three methods is highly subjective and also depends on the clinical experience. And for radiography, there's no information about implant stability. Bone mineral changes can be detected until 40% mineralization. So I suggest other method to check the implant stability, which is using ISQ, or implant stability quotient. This method is easy to perform and no need invasive procedure. ISQ is recommended to monitor implant stability. The suggestion time point is during implant placement, and then 3 weeks and the following 8 weeks post-surgically, until the minimum ISQ is reached. ISQ measurement values were found to increase within the healing time. The ISQ value and scale 1 to 100. And this one is different with the other test, which is subjective. This is an objective method of measuring implant stability. Higher ISQ means higher primary stability. And the recommendation, if you want to do the immediate loading of single implant crowns, is the ISQ must be more than 60. So how this tools works? So the technology is based on the tuning fork principle. A new sterile and disposable smart bag will attach to your implant and make it vibrate, just a tuning fork. And the purpose is to find the resonance frequency. This measurement is done very quickly, only a few seconds, and also non-invasive, reliable, and also objective. We can use some brands such as Osto or NSK Osio 100 to check this ISQ. And what the benefit of using these ISQ parameter? So we can help determine whether an implant is ready for loading and avoid premature loading, because we can measure whether the ISQ is high enough to loading the implant or not. We also can manage the patient with risk factors, especially with diabetes patient, which means that if the ISQ is low, we can check periodically whether the ISQ value is increasing or not. Avoid unnecessary wrong treatment times mean that if the ISQ is high enough, we can directly loading the implant and also achieve more predictable outcomes. Here is the ISQ values over time. Approximately value 70, it means that we'll have a good survival rate for the implant. If the initial ISQ is quite high, a small drop normally happen and it means no issue. But decreasing ISQ is a warning sign. Whether is it an implant failure, we must be a warning. Lower ISQ means that sometimes it means that you need to put larger implant diameters, or you can prolong the healing time before loading the implant. So as I mentioned that ISQ is objective, so let us see how the ISQ in well-controlled diabetes. Primary stability in a well-controlled diabetes is unlikely to be influenced. It is more strongly influenced by the implant position in the arch as well and as the type of the bone. The stability of dental implant was better at 6 months after placement than at baseline. The implant in this study demonstrate good osseointegration in well-controlled patients with type 2 diabetes. And this graph show how about the bone resorption around the dental implant. They compare the bone resorption for implant placed immediately after extraction and around areas that the teeth have been missing for less than 12 months. The mean extent of the bone resorption around dental implants placed in areas where teeth have been missing for more than 12 months was less if compared with the immediate placement after extraction. So this we see how the ISQ in poorly controlled diabetes. So in healthy condition, the minimum implant stability usually occurs in 2 to 4 weeks following implant placement. This will represent the transition from primary bone resorption to bone formation or osseointegration phase. This study shows 3 conditions, visit SH, which means systemic health, BCDM means better controlled diabetes, and PCDM for poor controlled diabetes mellitus. Patient with A1C 8.1 or poorly had a greater decrease in stability from the initial measurement and require a longer period for the return of stability to the baseline. We can see that the ISQ in 3 months for poorly diabetes dropped a lot, while for healthy and well-controlled is quite similar. According to this report, 6 months after implant insertion is more safe for implant loading in poorly controlled diabetes. So now how about the bone augmentation procedure? So I compare with the well-controlled and poorly controlled. For advanced implant surgeries such as GBR or GBR with a sinus lifting procedure is safe for well-controlled diabetes and have the same survival rate as those with normal condition. Also, other studies confirm the same conclusion about this. So the next slide will talk about how the bone augmentation in poorly controlled. Advanced implant surgery is safe if we talk about well-controlled, but for moderate and poorly controlled, it is suggested to avoid excessive surgical trauma. They recommend to use narrow diameter implant for sites with spatial limitation or reduce ridge dimension in an edentulous posterior region of either in maxilla or mandible. This study that compared narrow diameter implants to standard diameter implant revealed the widespread use of the narrow diameter implant. The diameter implant was used is a 3.3 to 3.5. be used to support whether the anterior and also the posterior restoration. Sorry, for the 8-year analysis, the narrow diameter implant placed in both premolar and molar, either single or splinted, the overall survival rate is very high and comparable to the standard diameter. So I think this can be a consideration for moderate or poorly controlled diabetes to use narrow diameter implant rather than to perform bone augmentation. So the use of narrow diameter implant, we can divide it into 3 categories. Category 1, which is less than 2.5 millimeters or known as mini implants, mostly is a one piece. And this is usually used for complete full overdenture case. Category 2, which is 2.5 to 3.3, and category 3 is 3.3 to 3.5. Okay, how supportive therapy really influence the survival rate of the dental implant? So this is mandatory if we perform implant placement in diabetic patient. Is we have to give the pre-operative antibiotics 1 hour before the implant placement. The antibiotics can be amoxicillin, clindamycin, azithromycin, or clarithromycin. Then you can continue with post-op antibiotics for 5 to 7 days, because we know that people with diabetes will have a high risk of infection and healing complication. And mouthwash using chlorhexidine also reported significantly increased implant survival rate. The use of mouthwash is recommended twice a day for 2 weeks. So this research shows how important is supportive therapy in diabetic patients. So don't forget to give the antibiotics and analgesic therapy after surgery. And you have to combine it with Mohn rinsing also with chlorhexidine. So with this therapy, diabetic patient will show the same implant survival rate compared with the healthy patient. Okay, according to this research, they compare 2 groups, with this group A with the no systemic disease and group B with the presence of diabetes type 2. So the marginal bone loss between group A and B were observed until 10 years. And this show no significantly different between both of the group. And they also compare the clinical complication between these groups, and no significant between both. So let's continue to the factors related to the implant surface design. So we will talking about the SLA and SLA active dental implant. Both actually are manufactured in the same way, but the difference is in the last stage of the production process. Which is the SLA implant are dry stored after sandblasting and acid etching, and SLA active after acid etching are rinsed under protective N2 gas condition and stored in an NaCl or saline solution. This will make a more active hydrophilic surface in the SLA active. They say that it will promote early bone apposition and greater implant stability during the first critical weeks of the osseointegration. So back again, this is the SLA and SLA active, a lot of research using diabetic animal. So if in an animal, we can use the BIC or bone implant contact. This is examined histopathologically well in human, we can use the ISQ. The conclusion is after 90 days, the SLA active shows significantly higher BIC compared to the SLA implants in diabetic animals. But the limitation of study is that the evaluation day only until 90 days. And the next is the research about SLA and SLA active in human. In different time exposure, they use the ISQ. We can see this is the graph. The A graph show ISQ in the buccal side and the B is in the lingual side. The ISQ levels decline after implant placement and by 8 weeks. Then after the following 8 weeks, the ISQ increase and then change minimally from week 12 to 16. The ISQ levels show similar pattern in both buccal and proximal direction. So the conclusion is implant stabilization was similar for the conventional SLA and chemically modified SLA implant in type 2 diabetic patient with poor control diabetes. So this is the same also about the SLA and SLA active in human. They compare well, moderate, and poorly controlled and take place in 3, 6, 9, and 12 months and 16 weeks following implant placement. And the conclusion is the same, that the first period after implant placement, the SLA actives show prior, but after 12 to 16 weeks following implant placement, the ISQ for SLA and SLA active is the same. Okay, now we will talking about factor related to the clinical procedure. So the first, how about submerged and non-submerged implant? So the study, 7 years follow-up about the peri-implant bone loss, which compare the submerged and non-submerged implant in diabetes patient. The research finding is that for non-submerged implants show more bone loss compared to the submerged. And they also reported close relation between A1C level and the peri-implant bone loss. So this can means that the higher A1C leading to greater bone loss. Within this finding, the recommendation is considering submerged implant and twice daily toothbrushing to decrease peri-implantitis in diabetic patient. So as we know that the bacterial growth is increased in diabetic patient. This is also the same report about non-submerged and submerged implant, which the finding is submerged implant more less bone loss, and the submerged implant, the bone loss only happen in the first years after the implant placement. So flap or flapless. So as we know, here is the advantage and disadvantage using flap and flapless surgery. And if you choose to use the flapless, it is recommended to keep the punch diameter smaller than the implant diameter. That will result in less bone loss. The advantage in a full thickness flap is we can see the ridge directly. In the flapless technique, the visibility is less. Okay, the research finding shows similar comparable result. That's why for flap or flapless in diabetes for single implant restoration, it is recommended the conventional full thickness than flapless. But the next slide, we discuss how about flap or flapless in a full edentulous patient. In a full edentulous patient, so we can know that the different approach must be performed. It means that avoid excessive trauma flapless, actually using surgical template must be considered for minimal intervention. And the flap group also shows significant higher plaque scores. So for edentulous patient, it's recommended to use flapless. And about the loading, whether we choose the immediate or delay loading. In well-controlled, no issue about this. You can also use the ISQ as your guidance, whether you can or immediate or delay loading while you're inserting the implant. These results will discuss about the moderately controlled diabetes, which is the A1C is up to 8%. They use 3 different implants, which is immediate implant insertion after extraction, or implant insertion 6 to 8 weeks following extraction, and delay implant, which means waiting for 4 to 6 months after extraction. The finding is bone loss was not statistically different with the healthy group. Anterior region demonstrate more bone loss compared to the posterior region, and delay implant insertion show less bone loss. So for moderate and of course poor, we must think about the delay loading than for immediate loading implants. But for the full overdanger or edentulous cases, it's quite different, because for edentulous cases, in Quite Journal, they say that both immediate and delayed loading protocols, even for flapless, can achieve a successful clinical outcome regarding the osseointegration and also preserve the marginal bone height. This is also the same that they say even for patients with A1C approaching 12, it seems that the success of mandibular implant overdanger is still okay. Okay, but for single dental implant placement in edentulous case, they suggested to delay loading than immediate loading. So before we are talking not about single dental implant for overdanger, but this one is a single dental implant, so you better delay for this case. So I summary and this is the recommendation about implant placement in diabetic patient. First is always monitor regularly the patient blood sugar level and maintain the A1C under 8. Then ask your patient to regularly visit dentist to prevent periodontal problems, and you should recommend it twice a year. Pre-operative antibiotics and mouthwash is very important to have better implant survival rate. And then you should avoid excessive trauma in poorly diabetes condition. Immediate loading can still be applied to well and moderate, but for poorly, it is recommended to postpone the loading until 6 months. I also suggested to measure ISQ periodically to decide when is the perfect time to loading the implant. Okay, so this is the end of my lecture. So I would like to give information about the seminar which will be held in Surabaya in the next February 4 and 5. This seminar is held by my department, collaborate with the Association of Surabaya Prosthodontics. This event will have a main lecture and also hands-on. So hopefully if you're able to visit Surabaya during that time, you can register and see you there. Okay, thank you for your time. Terima kasih, stay safe and healthy. I send back to the moderator.
Okay, thank you, Dr. Mefina, for the very great presentations. And I think there are so many great clinical tips that we can use from your presentations, especially about when we want to treat implant treatment in the diabetic patients. So for now, we will go into the question and answer sessions. And please, for the participant, if you have any question for our speaker, you can write in the Q&A box or in the chat box. For now, I haven't get any question yet. Okay, so maybe I have one question for our speaker, Dr. Mevina. You mentioned about using the ISQ. Have you ever tried another method using the like some kind of perio test, the one with the different like tapping system?
Yes. Actually, with tapping, as I mentioned before, these things is quite subjective and not objective. While the ISQ, we can see the number and it will be very objective test. I use ISQ in my patient and I see how they progress. The ISQ number increased during that time. And I think this ISQ can be very useful for us to determine when the perfect time for us to loading the implant, whether immediate or delay, or when is the perfect time. I think so. Back again, that the diabetic patient actually need faster to restore their mastication, so they can improve their quality of mastication, and then to also support their diet, and they can maintain their blood sugar level.
Yeah. Okay. Thank you, Doc. Maybe Professor Arshad. Do you want to ask some questions because you raised your hand?
My regards to Datu Ibrahim for arranging such excellent seminars in regular way, and especially I'm Lady Mefina. I'm very much impressed by your lecture. Actually, today in Pakistan, in Islamabad, one function is going on, and that is also for implant. And just I came back, and I was very much worried that I should join because Professor Ibrahim seminars are very precious for me. Uh, mm, Lady, I have few reservation and few questions for you, and especially when we are talking of ISQ. We have a certain limitation. ISQ is not available everywhere, and especially in the countries like Pakistan, affordability of the all the people, and sometimes it is not there. And ISQ standard, yeah, no doubt its parameter is very good, that it is numerical, that you can understand what is the intensity going on. Same question with the Emmy has asked that for a substitute to ISQ, whether we can have any other parameter. This is one question that I think that you have answered to some extent, but there is a one which we used to do, that is just by tweezer, and holding the head of the tweezer with a very light parameter, and assessing. If you are expert implantologist, you will understand the to some extent, I cannot assure you, but to some extent you can have the accessibility. This is the alternate to ISQ, which the expert implantologist can do. My second thing is that you have mentioned the NDI, and you have mentioned also the implants for the period, like the immediate implants, and then delaying tactics for the diabetes with reference to HbA1c. And especially I am talking of the thing of the implant, which is called bicortical implant, or what you call it a basilar implant. What is your idea about the basilar implant? because now they are coming very famous, and especially for prosthetic, immediate loading and like that. They are very much recommending. Have you experienced the basilar implant in diabetes patient for in your practice, or you have because I have not seen any study with reference to basilar implant, because these people used to give the implant immediately, and after 72 hours they used to get the loading of the implant. What is your idea about it?
Okay. Okay, thank you for the very long question. I try to conclude the conclusion for you. So for the ISQ, I know the problem because we are in Indonesia also have the same problems. And the problems is not only to buy the tools, but also to get the smart pack, which means the connector between the ISQ tools and the implant itself. So as I said, that ISQ is a very objective, while the others, it will be depends on the clinician itself experience. So if you don't have the ISQ, for my suggestion is we can see in the journal whether this is the perfect time for us to loading the implant. It means that if you think that the bone quality is not good enough, it's better to prolong the loading time. For me, I think that will be the idea if you don't have the ISQ. And then for the bachelor implant, I have no experience yet about that. So I'm sorry, I cannot answer and I cannot share with you about this. And about immediate and daily loading, as I mentioned, if it's for edentulous case, we can immediate loading the implant,
Yeah.
even in a poor
With reference to basilar implant, these are very thin. As you were mentioning NDI, it is, you can say that it can be substitute to NDI because it's a very thin, and it can bypass the nerves, it can bypass the maxillary sinus, and you can go up to the zygoma as well. So these are the very famous these days in Pakistan, especially. I'm saying that my two students, one recently he has started my postgraduate topic of basilar implant versus the routine implants. And secondly, what you are saying, the bone density, I think that Datu Ibrahim will be agreed with me that when we are talking of the bone value like D1, D2, D3, D4, and these values are entirely changed in diabetic patient, because these values, when you compare these value of the healthy person with that of the diabetic patient, this is entirely in a healthy patient what is D1, in diabetic patient it is D2, in a healthy patient it is D2, in the diabetic patient it is D3. So one step it is always forward, and as the HbA1c rises more than 6.5 and go to 6.8, or even one case you mentioned it is up to 12, and sometime you are on the losing side. So this is a very good suggestion that you must monitor the diabetic patient before giving any type of implant. Excellent presentation, and it has given a very good views to especially for the general practitioner and we people as well. So you have given so much good ideas and so much new information. Excellent.
Thank you. And so thank you for the great information about bachelor implant. I will read a lot after this about bachelor implant.
Thank you.
Thank
Okay.
you.
There is one question in the Q&A box. It's from Dr. Muhammad Kamal. He asked about how many implants that you recommended for upper edentulous patients for these diabetic patients.
Okay, so you can use the all-on-4, of course, and I think the guideline is for diabetes or for non-diabetes patient. The problem is back again. You can see whether they are the categorize with a well, a moderate, and poorly. That will be the important factors about this. But how to treat the patient edentulos in normal and diabetes? I think the same. You can use the all-on-4 for this kind. So it will be like when you want to treat patient just as usual. No big issue about diabetes and non-diabetes.
Mefina, if you permit me, can I answer?
Yes, of course.
Yeah. Well, actually, for the insertion of the edentulous, you are mashallah, very good prosthetician. I will just like to add here a few points regarding insertion of the implants in edentulous. Actually, it entirely depends upon the mesodistal width and the size of the mandible, and especially occlusive relation of the maxilla and mandible. If the mandible is small and if the mandible bone intensity is less, you are at a very compromised stage. Because if you are going to lessen the number of the implants, your stability will be compromised. And if you are going to increase the number of the implant, your survival of the implant will suffer. So in diabetic patient, it is a very big question that what is the size of the mandible, what is the size of the maxilla, and what is the bone or depth which you are going to gain. And same but your idea of regarding NDI, it is also a very big sign of interrogation in diabetic patient, because if you are going more NDI, you are going to have the more injuries and you are going to have a less stability as well. So it is entirely dependent on the jaw size, width of the bone, and the density of the bone. So before you are going to have these parameters, then you are going to, and especially I will say that if you are going for the flapless surgery and you have not gone for the template, or you are just going on your own confidence that I am in the occlusal plane and I am in the vertical level, or I am approximating to maxilla or mandible, so you are in hell. So for the diabetic patient, especially I will request that the template should be there for especially for flapless surgery.
Yes, I think I also agree. And we also see in the journal it's better to do flapless with the guided surgery for the diabetic patient, right?
Dr. Mefina, if you permit, I can just ask just one point of clarification. First of all, thank you for the excellent presentation, which you have outlined all the parameters that was good for implant placement, wear, and the blood sugar level. But this, again, you have not mentioned anything about comorbidity with other diseases such as smoking. Smoking and diabetic will make even the prognosis worse for the success rate. Maybe because to me, from what you said just now, it looks like even HbA1c 8 point more than 8, but 8 also is okay, because my HbA1c is about 8, so I that category. But I still got implant. Alhamdulillah, it's good. It's still working. But of course, luckily, I'm not smoking. So
that's. I just want to ask whether you're smoking or not.
That's right. But I think if we take care of our hygiene properly, I think HbA1c 8. We don't talk about other comorbidity. That should be okay in terms of placing implant, right, Dr. Mefina?
Yes, that's right. Because under 8 is categorized as well controlled. It means that the survival rate is similar with a healthy condition.
Yeah. All right. Thank you. Thank you very much. Ami, back to you. I don't see any other questions.
Yes, I don't see any other questions either. So
Okay, if no other questions, I thank you, Amy, for moderating the session. Of course, on behalf of Section 15, we'd like to thank Dr. Mefina for sharing a very informative parameters about diabetic patient and implant. So for us, a practitioner, as what Professor Ashad Malik, it is very useful guide for our patients implant. But of course, our webinar is on YouTube. So those who have missed your lecture, they can access on our ICT education channel on the YouTube to look back at your parameters, what is good, what is not good, what is about to method. Again, on behalf of Section 15, I would like to thank you for spending precious 1 hour or slightly more than 1 hour with our audience tonight. So hopefully we can meet you. Well, you have mentioned just now about your conference in Surabaya, isn't it? Yeah,
Yeah.
it will be Jakarta.
Oh, okay. Next, we'll have to visit Surabaya then.
But I wish I could there. But this one KPPIG by University Indonesia for lecture. But maybe next time, I probably will travel to Surabaya. All right. Thank you very much again, and I hope our audience tonight will be get a very good insight into diabetic and implant placement. Okay, as usual, we will continue our webinar for the month of February, and the speaker is in front of us tonight. So for February, we have for February. Sorry, just get my slide on. Professor Ashad Malik will be our speaker. So Professor Ashad Malik will talk about correct medical treatment approach of trigeminal neuralgia, a guide for GPs. Again, this is another guide for GP, Professor Ashad. So we hope that come and join us for this February webinar, and hopefully again it will be another good session with our audience. All right, and I think with that, I think we will call up for our tonight's session. Again, on behalf of Section 15, I'd like to thank Dr. Mefina and also our committee members, Dr. Amy and Dr. Nagam, who is online today, taking our records of attendance, and also the other two committee members are able not to join for other commitment. And for our audience, for the Chinese, we wish Happy New Year, Chinese New Year. May the year of the rabbit brings prosperity and whatever good fortune for us, for all of us in the year ahead. Thank you very much, Dr. Mefina. Thank you again, and hope to see you sometimes again in future. All right. Thank you and good night. Bye.
Thank you. Good night.
Good night.